Did you just talk
And
about?
we are now live, senators.
All right, we are live. This is Senate Health and Welfare on February 21st. And we're going to go through, Alex, it's the wrong draft.
Shoot. Oh, no.
We have draft 1.3.
We wanted 2.1.
We wanted 2.1. So if you don't mind, we'll start going through 2.1 using it electronically, but if you could ask him to print them out and bring them to us, that would be great.
But will do. Yeah, I'll do that now.
All right. All right, here we go.
All right, so looking at draft 2.1 of S37, a markup version of a strike all amendment to the Committee on Health and Welfare.
Thank you.
So for context, as you're reading this, so this version, you'll see yellow highlights that are not bolded language. This is language that is remaining from highlighting last Friday, but it was flagged for follow-up discussion today. If you see any bolded highlighted language, that is new language since Friday. Okay, starting first in the definition section, section 1. There are no, I'm scrolling fairly quickly, I apologize. There's only one change in here from the last version that you saw. There was a question about using the phrase secured by the state. So I have changed this to read in, for context, this is the definition of what is legally protected healthcare activity. So this subdivision C would say, on page 2, would say the provision, issuance, or use of, or enrollment in insurance or other health coverage for reproductive healthcare services or gender affirming healthcare services that are legal in this state, or any act to aid or engage or to attempt to aid or encourage any person in the provision, issuance, or use of, etc. these services. So I took out secured by and replaced that with that are legal in the state, because I believe that's really what we're trying to get at here.
And if you hear silence, that means keep going. We'll keep going.
Obviously. it's
Because we're not a shy
yes,
group, and
yes.
if you do have a question, just speak up. We don't, we just want to, have a discussion here.
All right, the next change or area that was marked for further discussion is on page 5, and now we're in the medical malpractice provisions. So you recall on Friday, we had some language that was included, and there was a little bit of questions and concerns about the use of whether a medical malpractice insurer could make a change to a provider's risk classification, premium charge, or other underwriting consideration based on the healthcare provider's claims loss experience. And so follow-up conversations with Jamie Feehan, he had forwarded me this new language below, which I think better captures the intent, because my question to him was, am I reading this correctly, that it would allow a medical malpractice insurer to use someone's claims loss experience as the basis for changing either the risk classification or premium charges or underwriting considerations, even if the person is providing legally protected healthcare and then they are sued for that. And so his response was that wasn't the intent of what they were trying to get at with this language. So he proposed this language, which I believe might have been in consultation with the Vermont Medical Society, to say instead, for purposes of this subdivision F, it shall not be unfairly discriminatory nor an arbitrary underwriting action against a healthcare provider if the risk classifications, premium charges, or other underwriting considerations are based on factors other than those listed in subdivision small 1 of this subdivision F. And to refresh our memory, those are not calculating or adjusting a healthcare provider's risk classification or premium charges on the basis that the healthcare provider provides or assists in the provision of legally protected healthcare activity that is unlawful in another state. Another state's laws create potential or actual liability for that activity. Abusive litigation against the provider concerning legally protected healthcare activity resulting in a judgment against the provider, or the license of the provider has been disciplined in any way by another state based solely on the provider's provision of legally protected healthcare activity. Okay, questions about this?
And so you heard both from the insurance folks and from VMS putting this together. That was does that work? Okay, I like it when everybody agrees. Nice.
Next, moving into section 3 on page 6, insurance coverage. Scrolling down to the areas that the committee had flagged for further discussion today. First was about coverage for gender affirming healthcare services that are medically necessary, and there's a question about what is medical necessity. I believe you were provided with some additional information from witnesses.
Yes.
So I don't know if you want to have any further discussion on that piece before I continue.
I think everyone saw the information that came to us regarding medically necessary, both from Dr. Gibson, her initial testimony, but then also the Vermont Medical Society connected with her again and sent additional comments.
Yeah. I would like to hear more from Vermont Medical Society today, and their suggestions. I'm concerned about mixing in medical stuff with insurance stuff and the problems that may cause with insurance companies making medical decisions, which is not appropriate.
So the question then is about the language before us, and Jessa Barnard, you're here. Can you comment at this point?
Sure, Jessa Barnard with the Vermont Medical Society. Thank you for the opportunity to comment on this section. And I did have a chance to briefly connect with Blue Cross and MVP just a few minutes ago as well. I think we are comfortable that the term on A, medically necessary and clinically appropriate, encapsulates a lot of what is actually now currently in yellow below that. So there are already standards that insurance companies use, not to speak for them, but whether that be clinical guidelines or prior authorization or ways to make decisions about what they cover, that I think see around listing out certain practice standards is not, I personally would recommend, or VMS would recommend, not calling out certain standards versus others, or having Department of Financial Regulation perhaps be the one. I don't think that's typically their role, is to pick out specific clinical guidelines, but rather we allow the insurance companies kind of do their current process, which is they can decide which guidelines are appropriate in consultation with their medical directors, the process they go through. That's kind of already allowed under that term, medically necessary, clinically appropriate. So we would recommend not including paragraph C or 2A below that around under prior authorization, because it also, we believe, medically necessary, clinically appropriate can allow for prior authorization, but again, it kind of calls it out in a separate way by listing it here. I have not heard back yet if DIVA is also comfortable with those changes, but I believe that Blue Cross and MVP would be comfortable with those.
Okay, so you're saying to strike big C and 2A. Okay.
And what about
And then
B, with 2B?
And what about 2B?
Personally, I think, I mean, again, you can hear from the insurers, I think they already have to comply with rules and guidance issued by DFR. So I don't know that it's a problem one way or another. I think that's already required of them, but whether you want that in language or not, I guess I don't have VMS does not have an opinion on, but the insurers.
So why don't we turn to who would like to go first, MVP or Blue Cross and Blue Shield?
MVP would be fine with B staying in there. Again, it's staying, and we completely agree with what VMS just said on C and A, that please remove those. But section B, we do have to comply. DFR is the regulator of us. We comply with every rule and guidance they issue, regardless of whether it's in the statute or not. So if you wanted to leave it there, we have no objection. If you wanted to remove it, we think it applies anyway.
Okay.
Sarah sent out with Blue Cross. Yes, I'm in agreement with the same.
Okay, so it's a committee's choice to leave it in or take it out, right? So I'd be happy taking it out. But
Yeah.
If it's like rewriting commercial health insurance statute in another place.
I agree. It just seemed like we were putting in all this extra language
Everything we
with
can.
gender affirming care, and it made me uncomfortable to say, we're gonna call this out specifically for this kind of care, and not any other kind of care.
So do we all agree then? Looking around the table, we okay then with taking out C1C, taking out 2A and 2B?
Alex, can you scroll down to 2A and B?
Oh, that's me.
Oh,
Oh, sorry. Sorry.
All right, so 2A is the prior authorization requirements. And B is commercial health insurance plans, compliance with rules and guidance issued by DFR.
I gotta do that. Okay. Terrific. What's next?
On the next section, we also had questions on the section 2, starts on the line 17, on page
Right.
7.
Which one, where are you? I'm looking at page 8. We have that cautionary language.
The,
Which, where are
in
you?
version, I hit the wrong version, darn it.
2.7, 2.1.
That's 2.1, no, I am on the right version, okay. The page 7 at the bottom, starting on line 17. The may be subject to prior authorization. That whole section was highlighted, and then it's the cost sharing section. Is it still highlighted in this version?
No, I skipped it.
And I have a note here about, is this more strict than other types of care?
Right.
And it seems, and this was the conversation we were having with Medicaid. I'm pointing this, that's where they were sitting last time, sorry. And just the discomfort with this whole section.
Yeah, so I believe we were discussing in subsection B, coverage, deleting subdivision C, the generally accepted practice standards. And then in subdivision 2, coverage provided pursuant to this section, deleting subdivision A, prior authorization requirements,
Okay.
that language.
Yep.
And then on page 8 in subdivision B, deleting that compliance with rules and guidance issued by Department of Financial Regulation, since that is already a requirement, whether you state that
You
here
just
or
took
not.
that out.
I have in here Medicaid and or any other public health care assistance program shall comply with all federal requirements imposed by the Centers for Medicare and Medicaid Services. I had not had that flagged from last time because there was not a comment around that. And then subdivision 3, nothing in this section shall prohibit a health insurance plan from providing greater coverage for gender affirming healthcare services than is required under this section. I did not have that flagged either for discussion. I did still have the cost sharing flagged, removing the sentence, the coverage required by the section shall not be subject to any co-payment, deductible, co-insurance, or other cost sharing requirement or additional charge. And instead having alternate language that says a health insurance plan shall not impose greater co-insurance, co-payment, deductible, or other cost sharing requirements for coverage of gender affirming healthcare services than apply to the diagnosis and treatment of any other physical or mental health condition under the plan.
Yeah, I have it checked off, but maybe someone who was concerned about that.
I guess I'm still a little concerned. I mean, our original thought was the no cost sharing, and I understand why that, because the gender affirming care is so broad, that's that might be a concern. But I feel like this language, because it's so broad, like what is there's no security in that they, in saying, well, this isn't any greater cost sharing. I guess I don't understand how this would work in practice.
So this would be an insurance company question.
Well, and if I can add,
First, Jen.
This is fairly standard language. We have in a number of insurance mandate sections where coverage is required. And there's language saying it can't have a greater cost sharing requirement than for anything else under the plan, which means it sort of has to have the lowest level, or at least lowest level in that same kind of comparable, whether, primary care or specialty care. I think there's some room to have it be at the right level for the type of care that it is. But there is certainly experience with the health insurers and DFR in interpreting that language in the policies. And then I don't know if the insurers.
Yeah, do either of you wish to speak to that?
Sure. Sarah Teachout with Blue Cross and Blue Shield of Vermont. So for gender affirming care, if the person is seeking mental health care, they would have the same copays as anyone else seeking mental health services.
More.
But not more, correct. If they were purchasing medications, it would be the exact same out-of-pocket costs for any other medication in that class. If they were going for inpatient or outpatient surgery, it would be the same copays or deductibles for those services as any other type of inpatient or outpatient service. And so there is a basis for comparison, basically. Like, I was like, what do you compare it to? But it sounds like you would take it case, like individual type of care by individual type of care, like you just described. So
Yes.
yeah. So, okay, the one other question I have is on line 15. Physical or mental condition, is that standard how you say it? Okay, thanks.
We're good. Did MVP want to weigh in on that?
No,
We're good? Okay. Good, that's helpful. Thank you.
Next, moving into section 4, coverage for abortion and abortion-related services. There was a follow-up item for me in subsection E, coverage. The draft 1.3 had subject to requirements under federal law, and there was discussion about, is that going to be in some way read as limiting coverage under this? And I was mentioning the federal requirements around funding for these. And in looking to this, I don't believe that this phrase would limit coverage, but I also, when looking into it further, don't believe it's necessary to include, since it is about the funding piece. Insurers and Medicaid are already required to follow federal requirements. So I don't know that the phrase is necessary, and if the committee feels that this would be possibly seen to be adding some sort of limit on coverage, then I think it would make sense to take it out.
Any questions there on that one?
I believe when we walked through this section on Friday, I'm not sure, I read the deletion of subsection C, cost sharing. The coverage required by the section shall not be subject to any co-payment, deductible, co-insurance, or other cost sharing requirement or additional charge. So I just wanted to make sure that the committee was comfortable with removing that language.
Yeah, I think we realize how expensive that is.
Well, in this case, I actually,
Abortion-related care.
it's not that expensive compared to other things. I mean, I understand with gender affirming care, it's a whole host of types of care, but abortion care is a generally more or less a 1 or 2 visit
Yeah.
situation, and it's not, I actually think we should keep that language.
So this is a good place for us. We'll ask the question, both of Medicaid. I don't see Diva in the room. Does Medicaid have cost sharing? No.
For prescription drugs, they do.
Yeah, but for abortion care,
Typically, there's not cost sharing for most services. I don't know.
There's certain very limited circumstances when there is, and I don't know what thoughts are
Right.
that this
The
type
more
of care
complicated.
would fall into that.
so I think we're gonna have to reach out to Diva about this, but then also I'm looking at our 2 insurers in the room.
Sure. Sarah Teachout with Blue Cross and Blue Shield of Vermont. If you would like to eliminate cost sharing for abortion, we do need the phrase in there saying that people with high deductible health plans cannot have first dollar services, so they need to be excluded.
That was in gender affirming care, yeah.
Yeah.
And this, I think what they said, if I remember, is that for medication abortion, they would still have to charge the $3 copay that they charge for medication, prescription drugs.
Yeah, I think that's the only place that there's cost sharing in Medicaid for abortion, but you'll be checking with Diva.
Can we reach out to them and ask them? And this is not, we don't need to have them come in to answer. We can reach out and ask that question of you. Senator.
Ma'am, just curious why the cost sharing language from the gender affirming care section might not be applicable to that.
Well, I think the original thought with the bill was that we wanted to make sure that this type of care was easily accessible, given that it's under attack in other places. But the complication with gender affirming care is that it covers such a broad swath of types of care, mental health care, you know,
over a long period of time.
and over a long period of time. So it may not be as
Complex.
feasible to do it as no cost sharing, but for
Right, I'm not saying it
abortion-
that way, but yeah.
So for abortion care, it is a sort of one time, sometimes there's a follow-up, sometimes there's not. You know, one time kind of incident, it's generally not very expensive at all in terms of what the insurance company, and a lot of insurance companies already don't have cost sharing. So just to sort of make it clear that there's no cost sharing, that it's accessible and that there's not a delay in care, because a delay in care can make it more expensive and more complicated if there's a delay.
Well, so then the question is, what language do we need to put in here related to the high deductible plans, if any? And how does Diva view this?
How does Diva view this?
Does Diva, is this okay with Diva, just to reach out and ask that? Are there any complications? So I'm thinking that if there is a more complicated case and that abortion is solved, it might be very expensive. So that included here. There are so few of these that it might be benefit, a useful benefit. I'm asking you to think about that from the insurance side, and we can ask Diva.
Sure.
I don't know, I have no idea what the fiscal note would look like.
So Sarah Teachout with Blue Cross and Blue Shield, there are very few of our members receiving abortion services every year. So the cost is not significant in the big scope of the cost of medical care. I would say that because federal IRS guidelines require that we do not pay first dollar care for anyone who has a high deductible health plan, that they're using an HSA or HRA, there are very, very few people who will be impacted by this change as well, because you have to exclude them. And then just to state, I learned a new fact last week when I asked about the VHI, which is also covered under here. 90% of people covered VHI have a high deductible plan. So, but they have a very low cap, and they also have it paired with an HSA or an HRA that's filled by the their employer. So they do have coverage for the most part.
Okay, thank you. So leave it to you to frame.
So either way, it probably doesn't have a huge,
Yeah, it does not.
whether it's in there or not.
Yeah. Okay, so.
Right, I think, but to Sarah's point, if you do decide to say no cost sharing, then she's right that you do need to have that carve out in there for the high deductible
Yeah,
plans.
you gotta
or
say
you will
something.
make people ineligible for an HSA. And I don't believe that is the intent.
Right.
Let's go ahead, Senator.
Just a question, and it may not be applicable to this discussion, but I can see as we're talking about the gender affirming care, if the Medicaid, if the state is gonna pick any of that up, I can see the dollar signs on the calculator increasing. And some of the constituency may have a question about what the actual cost is gonna be. Not that it matters to what we're doing here, but is that something we're gonna learn?
Well, we're not putting that coverage in. We're allowing the Medicaid coverage will continue as it is. So it's not, we're not giving carte blanche for full coverage for gender affirming care. And for all the reasons that we just said, it begins and it continues. It can continue for a long period of time, can use complex medical procedures and treatments. So, yeah, I think we got that. Okay, yeah, good question. Okay,
Ready to move to the next section?
yes, please.
Moving over to professional regulation for section 6. See, I have highlighted language in here. This is, I cleaned up the markup version that you saw last Friday, so it still has the new language highlighted, but I have not made any changes since what you reviewed on Friday. So this section would now read, notwithstanding subsection E of this section or any other law to the contrary, no healthcare provider shall be subject to professional disciplinary action by a board or the director, nor shall a board or the director take adverse action on an application for certification, registration, or licensure of a qualified healthcare provider based solely on, 1, the healthcare provider providing or assisting in the provision of legally protected healthcare activity, or 2, a criminal or civil action or disciplinary action against the healthcare provider by a licensing board of another state based solely on the provider providing or assisting in the provision of legally protected healthcare activity.
I have this checked off, but was there a question? Did someone have a question about this section?
I believe we hadn't heard from the Office of Professional Regulation yet,
That's right.
or the Board of Medical Practice about this revised language. It's had it flagged because we had not had any testimony on the changed language.
Okay, and we are going to hear from Department of Health on the bill, so we'll hold this one open until we have heard their testimony.
And then moving into section 7, the previous section 6 was for professions regulated by the Office of Professional Regulation. Section 7 is for those professions that are regulated by the Board of Medical Practice. So this is largely identical language, except it's talking about the board rather than a board or the director. It's substantively the same.
We need to reach out to OPR on this again. I think so.
Read the bill.
Yeah, she's good. Okay. And remember you said that. Okay. Where are we? What page?
Now moving on to page 12, this is pregnancy centers, starting with section 8.
Okay.
I know we are scheduled for noon.
No, so this is a good place to stop, I think, because we'll have to go through this, and when do we have this scheduled again?
I believe 8 a.m. tomorrow.
Oh,
Nice
8
and
o'clock?
early.
Who did that? Okay.
You and
I think Senator Week suggested that.
Oh.
No, he did, but I'm not.
I'm not sure.
So what we'll do is we'll call it a wrap today, and we will be back here at 8 a.m. tomorrow. So Alex, you can take us offline. Wait.
Yes, before you do that, I just mentioned, I did
Yes.
send you some, or have posted today, some of the language from, let me back up. You've heard a couple of references to notice and disclosure requirements around stem cell related procedures. So for posted today, you'll see the notice and disclosure language from that section of statute about the stem cell related procedure. So I have that flagged in here as a question for the committee about whether they want to look at that, whether they're interested in doing any notice or disclosure requirements. And as that was suggested by a couple witnesses as an avenue to explore. And so that is up there for your.
Okay.
You want to take a look.
Posted on the committee.
We have it on the
Yes.
webpage from
Yes.
Ameren, I think. It's on the thing. S's and so. Okay, now we can wrap and go off live. And then tomorrow morning.